in terms of some of these other uses of the EEG, sometimes we'll combine the sleep study with an EEG. We call it EEG polysomnography to try to detect seizures, sleep terrors, also called night terrors, sleepwalking, head banging. And I want to make a pitch here. When we try to bring families into the lab and bring kids into the lab and we want something to happen, it won't, even if it's happening every night. There's something about being in an unusual, a different place that somehow suppresses these events. So I really encourage the families, especially now with cell phones being so prevalent, to try to capture what their child is doing on their cell phone and bring it to the clinic visit. And this has been enormously helpful because oftentimes you want to not just see one, you want to see 3 or 4 of them because you can see if they're similar. If they're similar, it makes you worry about seizures, particularly if there's some stereotype movements. And that's what I'm going to get to next, is I want to describe what these are and show you some examples. So let me pull up my videos. So the first one is an example of sleepwalking, and this is actually something I brought with me from the University of Michigan because it's such a classic example. Let's see, opening, okay, there we go. And what you see in this video, this little girl is going to make multiple attempts to get out of bed, and she finally is going to be successful. And then if you look here at the EEG, there's high waves. It's a lot of dark lines, but there's a lot of like high waves with a lot of space between them. And that means she's still asleep. So even though her eyes are open and she's getting out of bed and going back into bed and rearranging the covers, she's actually still asleep here because the EEG is showing sleep activity. And what you're going to watch her do in a moment is get out of bed. She finally makes it. And then she kind of does something that the sleep techs I show this to find incredibly funny. She starts destroying the evidence. She starts unplugging the box that her wires are coming from. And she does it pretty vigorously.
Danielle, what are you doing? Nothing. You just unplugged all those wires. Yeah, no. Why'd you unplug them? Why?
So she at least isn't admitting why, but anyway, she wakes up somewhere in there. We're not sure where because she took off all the wires, but. And then seizures are really interesting. I want to show you 2 examples of seizures, and I want you to see how similar the seizure is. This is the first example. This is a young woman with frontal lobe epilepsy, and watch her left arm, which is under the bed sheets, extend. You can see that right here. And now it's lifting up, it's out of the bed sheet, and it's coming over her head. Her right arm is extended out. It's like, we call this a fencing position. And what's happening is the video is showing you the event, the EEG is showing you the seizure activity. And then I have a second event in the same young woman that was taken from the same night. She had like 11 of them in one night. And you can see how similar it is. Here the bed sheet isn't covering her arm. It's the same thing. One of the arms is flexing over her head. The other arm is extending. And she has these jerks. And this is a seizure because it's the same parts of the brain are firing every time. And there's clonic activity, there's the stiffening. So even without the EEG, that would be highly suspicious of a seizure. And that's something we can record in the lab. There's also something that parents can record on their phones, and then we can decide if we need to bring the child in for a sleep study with a full head EEG. This is an example of another type of epilepsy called benign Rolandic epilepsy. And the benign part is they oftentimes outgrow it. The Rolandic is it refers to the part of the brain that controls movement of the face and motor areas, and you can hear it as well as see it. You see that movement of his mouth. And they're very short, and we were lucky enough to capture it. He had actually come in for rule out sleep apnea, and he had one of his typical seizures while he was here. And then the other things that can happen besides seizures, and just to say, so seizures are epileptic activity caused by disinhibition of the brain. It can occur in any part of the brain. The part of the brain that it's occurring in is how it manifests itself, although it can spread from one area to another. So just because you see somebody moving their arm doesn't mean it's starting in the part of the brain that controls arm movement. It could have started in a deeper part of the brain and moved to the part of the brain that controls arm movement. But we can put this all together. Oftentimes what we're doing as sleep specialists is just making the diagnosis of epilepsy, and then we refer to an epilepsy specialist for treatment, for better characterization. Yes?
Two questions. I think I know the answer.
Yeah.
To this one, but epilepsy is genetic, right? There's some genetic, I think that there's some...
Right. Epilepsy can be genetic. It doesn't have to be. In other words, there's oftentimes certain, like the benign Rolandic epilepsy that I just showed you is a genetic epilepsy syndrome where either it runs in, it's autosomal dominant either for the seizures themselves or else for the brainwave activity that accompanies it. But some forms of epilepsy may be de novo.
And could parents tell, like, could we tell if a child was doing some kind of behavior while they were sleeping? Could we tell if it was a seizure or if it was just some kind of movement thing?
Right. So the question is, how do you know it's a seizure or not a seizure? And again, what we ask for parents to do is just to make their healthcare provider aware there is some sort of recurrent event that's happening and to describe it as best as they can. And if they can, bring in a video on their cell phone. As clinicians, what we're interested in is there something where it sounds like it's the same thing every time, where the parent describes, for example, the left arm is always flexed, or the child is making chewing movements of their mouth, or a clicking sound like I just showed you. Is the event occurring multiple times throughout the night as opposed to just being in the first part of the night, which might suggest what I'm going to show you next, which is the night, or what I showed you earlier, the sleepwalking, where it's happening in the first part of the night when we're seeing that deep sleep. So I don't ask the parents to know all of that. I just ask them to be cognizant that there is an event happening that isn't, it's unusually different than the child is just waking up and needing something. The child may look like they're asleep. The parents will say that the child is inconsolable. They'll be staring off. Something that just does not look like a normal awakening. Does that help? Okay. And then the other category where they can seem like not themselves is not just the seizure, but the sleepwalking that I showed you. And sleepwalking, night terrors or sleep terrors, and confusional arousals all kind of go together. And these are all in the first part of the night for the most part. They're in deep non-REM sleep, although sometimes they can be in lighter stages. The night terrors, which I'm about to show you, the child can be inconsolable, difficult to really arouse. It's a little blurry, but the reason I wanted to show you this is for the scream part, which is about to come up. It's like a blood-curdling, really disturbing scream. that, you might say, well, why isn't that just a night waking? What parents will say is they could not console their child. They didn't seem to be awake. They didn't seem to be interacting with them. Again, it's oftentimes the first part of the night, doesn't recur as the night goes on. And it's tricky. I saw a child in clinic Friday last week before I flew up here, and it was at 11 o'clock every evening, they had this type of event almost every night. But then at 3 a.m., they had a separate event where the child got out of bed and walked to their parents' room and asked for things. So it's not unusual to have two different things going on in the same child. And the treatments can be very, very different. In this case, this really begs for me to make sure there's no underlying sleep disorder that's disrupting the child's sleep. I would oftentimes look for sleep apnea. I would try to make sure I wasn't worried about seizure. I would put on a full head EEG if I was concerned, so I could look at the EEG as well. I would also see if the parent could capture some videos that I can look at. The child coming and waking up the parent at 3 a.m., being fully awake, being coherent, is not as concerning. There still could have been something that woke up the child, like sleep apnea or whatnot, but it's very different, a different set of considerations that I would have for wanting to investigate. The other one is the head banging, which can happen at any stage of sleep, and is often felt to be something the child is just doing, but is real and is not necessarily deliberate. Some children with autism or other developmental disabilities may actually headbang during the day when they're fully awake and coherent as a way of relieving stress, or it can be a sensory-seeking behavior. However, kids can also do this in their sleep and be unaware of it. It's very hard to treat with medication, and the treatment oftentimes that we've found to be most effective is to use a soft helmet, because we don't want there to be any injury to the head, and also the proprioceptive or the tactile input that the child can get from the helmet can sometimes help the head banging. But this is a very commonly seen and very, it's not always entirely benign, because the child can hit their head against the headboard or hurt themselves in some way. So those are the videos I brought to give you just a few examples of what we sometimes see in the sleep lab, what we capture. Before I move away from the videos, does anybody have any questions about them? I could take a couple questions, yeah.
Sorry, so is the head banging also associated with sleep apnea, or because during the day it may be a seeking behavior, but not necessarily at night?
Correct. So at night, the point I wanted to make is that children can have head banging and be totally asleep, and it can come out of any stage of sleep, and they could stay asleep during these. So we don't want to confuse these with sensory-seeking type behavior.
I have a question.
Yes?
The sleepwalking, they don't necessarily get out of bed, and is it a tremendous amount of movement where their head is at the other side of the bed?
Right. So the sleepwalking, I tend to put on the spectrum with confusional arousals or sleep terrors. Sleepwalking, oftentimes, they'll stand up, they'll get out of bed, they can wander throughout the house, but on that same spectrum is just waking up and moving around the bed and acting confused. And probably the most important thing in those cases is to be aware of safety measures. Let me just show you before I go on to the safety measures slide. This is an example of something we might capture on the EEG. This is a 21-channel overnight EEG that goes with the sleep study. And you can see here breaking up the background are these high waves that disrupt the background, and that is evidence of an epileptic seizure. And then the safety issues are probably the most important, and this holds not just for the episodes I talked about, the sleepwalking, the sleep terrors, the confusional arousals, possibility of seizures, but even for night wakings where the child is awake and alert. Use of gates, locking outdoor doors and windows, lighting of hallways, eliminating floor clutter, avoiding frequent rearrangement of furniture, blocking access to kitchen, bathrooms, mattresses on the floor, use of a sleeping bag to reduce wanderings, and then also notification measures so the parent knows that the child is up. And it could be a sophisticated alarm system, but it could also be bells attached to the door. It doesn't have to be really expensive, but it's something that alerts the parents to the fact that their child is out of bed and makes sure that they're safe.